Good evening, everybody, and welcome to tonight's presentation on voluntary assisted dying, the role of the general practitioner. This is a collaborative webinar tonight with Gold Coast PHN, Gold Coast Health, and the Queensland Voluntary Assisted Dying Unit. Just as we kick off, a reminder that this event is being recorded, and if you can all keep your microphones muted and your cameras off. And this evening we are going to hold all questions over to the Q&A session at the end of the presentation. It does get a little bit it is a bit difficult to keep track of all the questions when they go in the chat. So if you do have questions, please hold them over until the end of the presentation. And of course, the event is being recorded and available through the Gold Coast PHN website over the next few days. And a link will be sent out with the recording and all of the resources that are discussed tonight. Before we introduce our speakers, I would like to acknowledge country. Gold Coast PHN would like to acknowledge and pay respect to the land and traditional practices of the families of the Yugambeh language region of the Southeast Queensland, and also acknowledge their elders past, present and emerging. So we have, for tonight's presentation, we have a number of guests.
Inga, you're on mute.
Sorry, Inga, just unmute yourself.
That's all right. Where did we get up to?
Number of speakers.
Number of speakers. So we've got Dr. Bav Manoharan, we've got Dr. Fabian Jaramillo, Tricia Mathias, Leslie McLeod, and Tamron Darch. We will kick off with Dr. Manoharan this evening, who is going to provide an overview to the voluntary assisted or VAD process, and also provide an overview of what the role of doctors and healthcare workers is in this space, and also discuss some learnings from our Interstate and New Zealand colleagues. We'll also have a bit of an update from Fabian around HealthPathways. Leslie will provide an overview of the statewide support and pharmacy services. We're also going to include in this discussion tonight what some of the rules and guidelines are around any New South Wales or Northern New South Wales residents who are seeking to access the service in Queensland. And finally, Gold Coast Health will speak a little bit about the model of care and, of course, the referral process for us here on the Gold Coast. So to kick off tonight, Dr. Manoharan is going to be the first presenter, and Dr. Manoharan is the clinical lead for Queensland Health for VAD, and is focused on ensuring voluntary assisted dying in Queensland is high quality, safe, accessible and compassionate. He was heavily involved in the Australian Medical Association submission in response to the VAD bill, parliamentary inquiry, and before coming to this particular role, he was the State Clinical Director for Queensland Health COVID-19 Vaccination Task Force and Vaccine Command Centre. So I'll hand over to you, Bav, and we'll see you on the other side.
Thanks, Inga. So I think whilst our slide deck's being put up, I guess I'm wearing two hats here. One is with my statewide VAD implementation role, but I also work at the Gold Coast HHS as the Deputy EDMS and Tamron, who's here as well from the HHS, we can answer some questions down at the end toward about what the HHS is doing and how you might interact with them. But I just wanted to introduce what voluntary assisted dying is and go through some slides. But before I do that, I'd like to acknowledge that I'm here on the lands of the Yuggera and Turrbal people in Brisbane, and pay my respects to elders past, present, and emerging. And also voluntary assisted dying, or as we call it, VAD, is quite a complex issue. It has a lot of people have a lot of different views about it, and we treat all views with a lot of respect. And I think the diversity in views helps make, certainly with implementation, has helped us shape a program that is equitable and fair to the patients, and also looks after the views of our practitioners and healthcare workers more broadly who are going to be involved or see patients. So I think this has been quite an important aspect of the implementation. And again, today would be very keen to make sure our discussions remain that way. So a bit of an agenda. I think Inga's covered this off, so I won't dwell on it, but we'll talk about a bit about the legislation, a bit about the role of doctors and healthcare workers, and then I'll hand over to Fabian, and we'll talk about a bit about what's happening at the statewide level for support. This will be particularly important next year if you're seeking advice or support from the statewide service, and then some of those particularly Gold Coast specific issues about patients that might live south of our border, and then the local process at the Gold Coast HHS. So voluntary assisted dying is specifically an option that's available to people who are suffering and dying who meet the eligibility criteria. It's an option of medical assistance to end their life. Now, we use the term voluntary assisted dying in Queensland, as is used in Victoria and WA. The legislation in Queensland specifies that this is not suicide and different to suicide. We don't use the terms euthanasia or physician-assisted suicide. You'll see that terminology overseas, but for the most part, all the other states in Australia have legislated VAD and at different stages of implementation, and it is going to be called VAD. So that's a terminology that we use. It'll be available in Queensland from the 1st of January next year. So about 24 or 5 business days away, about 5 or 6 weeks now. So not very far away in the future. We certainly know that our consumers who are interested in this know about it, and we've already started getting a lot of inquiries from the public about VAD and how they can prepare, especially those who are interested in accessing it. So we'll talk a little bit about the eligibility criteria. There's 5 main eligibility criteria, and the first one is the condition itself. So the condition has to be advanced, progressive, and will cause death. So that's your diagnosis. And then the second element is it's expected to cause death within 12 months. So prognosis. In Victoria and WA, their prognosis period is around 6 months for most medical conditions, and then for neurodegenerative conditions, it extends up to 12. In Queensland, it's been made 12 for both under the legislation. How that impacts our numbers and the flow of people coming in when they come in is yet to be seen. So it is something that we'll be looking at and monitoring. That condition needs to be causing suffering that the person considers intolerable. So that is a very subjective thing, and it's going to be person dependent. Some patients might potentially not necessarily see their suffering as intolerable, and the same set of symptoms might be intolerable to someone else. Now, those conditions have to be assessed by a doctor, and we'll talk about that in a sec. But the other eligibility criteria around having decision-making capacity. Now, this is important because it's different to decision-making capacity and slightly different to decision-making capacity in normal healthcare, where as you start to lose capacity because of your condition or because of just age-related mental decline, you can leverage a substitute decision maker or a advanced health directive, EPOA, and you have those usual types of amenities. Unfortunately, in voluntary assisted dying, you need to retain decision-making capacity throughout the process of accessing VAD. And if you were to lose decision-making capacity in any one of the steps that we'll talk about, you may become ineligible. And we know that decision-making capacity is not a black or white. There's a lot of grey space, but that's an important feature. You need to be acting voluntarily and without coercion. You need to be above 18. And you need to fulfill some residency and citizenship requirements. I won't dwell on that too much because we will talk about that a bit more in detail when we talk about what we do about border residents. But essentially, you need to have Australian citizenship or permanent residency and a demonstrable link to Queensland. So I just want to run through the process. So this is how the legislation has broken down the various steps of the process. So you'll see that there's this thing called a first request. So a first request is where a person asks a doctor, has to be a medical practitioner doctor, for assistance to end their life. It has to be clear and unambiguous. It has to be made by the person. So it can't be made by a spouse, their carer, a child, or a sibling. It has to be made by the person. If there's issues around that person's communication, as in if they need an interpreter, that's permitted under the Act, or if they have a speech impediment and they need a speech pathologist to assist, that's also enabled, but it has to be coming from that person. If they're, for example, requesting information, that's not necessarily a first request, but we'll talk about that in a bit more detail later. Once they've made a first request to a doctor, if the doctor accepts the first request, there's a first assessment, which assesses against those eligibility criteria. And then there's a second doctor that has to do a consulting assessment. And that's assessment by a second independent doctor, sorry, a second doctor independently assessing those eligibility criteria. So there you have two doctors who've agreed that this person meets the eligibility criteria, and they can then progress through a series of request phases where they need to get witnesses and complete some paperwork. And they have to wait 9 days between the first request to when they can make their final request. And the 9 days is there to make sure that their decision is enduring. It's not a fleeting decision that they've reacted to because potentially they got some bad news about a diagnosis or something else. It is something they've thought through. The next stage is, assuming that they've met the eligibility criteria, is an administration decision. So that's where the coordinating medical practitioner sits with the patient and really talks through the options for VAD. So there's two options, self-administration and practitioner administration. And self-administration is where the substance is provided to them via our statewide pharmacy service, and they can ingest that substance at some stage that suits them. They can make their plans. We know that about a third of people take that substance shortly after they receive it in Victoria and WA, but quite a few people actually hold on to it. And there's a certain large proportion of people who get given the substance don't actually die from taking the substance, they die from their underlying condition. So there's a sense of reassuredness of having access to it. Practitioner administration is the other modality. The default is self-administration, and it's about 80% of people who go down that pathway. And then there's a few people who will go down practitioner administration. That's where practitioner is provided with a separate set of substances, either IV or for NG or parenteral insertion, but generally it's going to be an IV kit. I won't go into too much detail about that because if you are interested in becoming a practitioner, you'll have to go through the training and it covers that off. The substances are supplied, and there's some requirements around disposal on the person and their contact person, and then death notification. And the death notification is important for all of you to know about because even if you're not looking after a patient who in the journey of their VAD and you become aware of someone who's died of taking a VAD substance, there's obligations on you as a medical practitioner to write a cause of death certificate, but also around notifying the VAD unit, the VAD board, that someone has died from VAD. There are requirements when you're documenting in a death certificate, cause of death certificate, that you don't actually document VAD. It has to relate to the underlying condition, and there's additional guidance on that in our handbook online. So go to the next slide. This talks to the operational structure of VAD. So we obviously will have the practitioners on the ground who are doing providing VAD services, and to support them, there'll be a statewide service that is providing support around for practitioners as well as for patients, helping patients be navigated to practitioners that can assist, and then the pharmacy, which does all the required things with the actual substances and delivers those substances to either the patient or the doctor. We have the VAD unit, which looks after the policy elements. It'll look after any residency exemptions, which you'll hear about shortly. And also, if you apply to be a VAD practitioner, that's the unit that you're applying to, and they manage that process. And on top of all of that, there's a review board that reviews the cases that occur in Queensland and provides a retrospective assessment process just to make sure that the Act's being followed and there's compliance. So we're lucky in Queensland, if we go to the next slide, that we're not the first, and we're actually the fourth state. South Australia has just gone live recently. Maybe it was Tasmania. I keep mixing the two up, but recently. But Victoria and WA have been providing VAD services for some time now, and so we know from their data that most people who try and access VAD have underlying malignancies as the underlying condition, and then the next biggest group is neurodegenerative conditions, and most of that relates to motor neuron disease, Parkinson's. There's been anecdotally some patients who've had early onset dementia, but that really goes hand in hand with that sort of patient demographic. They're in their 70s and will have other comorbidities. We know from Victoria that most people, or 2/3 of people, live in population centres. We expect similar patterns in Queensland as well, so the southeast corner and perhaps around Cairns and Townsville. Whilst we don't consider VAD to be part of palliative care, it's certainly an end-of-life option, but it's separate to palliative care. We know that from Victoria and New Zealand that about 80% of people are accessing palliative care when they start to access VAD. So patients don't necessarily see them as mutually exclusive. So that's something to keep in mind, because very conscious that palliative care is delivered in primary care as well. It's not just a specialist palliative care type thing. So you will have patients who are seeking active palliative care and support at the same time as considering VAD potentially. So on the basis of the numbers we have from Interstate, we've done some projections in Queensland. And so we expect that we'll have about 1,000 first assessments and about 400 people dying as a result of progressing through that pathway from taking a VAD substance. So those numbers are obviously projections. And on the Gold Coast, we anticipate we'll have about 150 or so first assessments and resulting in about 50 to 60 deaths. And that's in our region, not necessarily primary care or hospital-based, but we're really hoping that there's going to be some GPs in our region that also do the training and assist in looking after some of the patients that come through in the VAD space. So we had a recent conference, and Claire Fellingham, who's a doctor based out of WA, who was their clinical lead in their implementation and undertakes some VAD activity, provided some very useful insight into what she found, her experience of being a VAD practitioner, and really spoke to how it's unlike all the other types of care that we provide. She found this particularly one where it was truly person-centered. It was quite an enriching experience because death is never good or happy, but this does provide people with the option of a good death that they can control and have autonomy over, and really there was a lot of meaning associated with it, and it was quite a respectful process that she found. It's really driven at someone's choice and pace. As I said earlier, some people have this substance and they don't actually die from taking it, but the reassurance of having it available is sometimes quite an anxiolytic to them. So it's around that good death, being dignified, calm, and compassionate. And so she found the whole experience quite powerful, and we had a lot of other experiences shared from other practitioners interstate, and those recordings actually can be made available on our website. So if you do get some, if you are interested and have some time, we can certainly you can certainly go and check them out there and access the conference recordings as well. And I'd encourage you to do so. I just want to talk very briefly about the role of healthcare workers. So we've briefly talked about the top three, which is coordinating practitioner and consulting practitioner, the two doctors that need to do the assessments. They need to be eligible doctors who've gone off and done the training. Most of you on the call would be eligible doctors. You're specialists for at least a year as GPs, or you've had 5 years of general registration. And then administering practitioners in Queensland, that includes doctors, who are the first two types, but also can include nurses and nurse practitioners. And that's really to assist us in, if we do need to get out to rural, remote and regional areas, or reduce the workload on our doctors, we can transfer some of those duties across to our nursing colleagues. In Queensland, you're allowed to initiate conversations about VAD with a patient, as long as you do it in the context of other end-of-life options, palliative care as an example. You can't do that in other states, in Victoria particularly, and so can nurse practitioners. So if you have a nurse practitioner in your practice, they can certainly be involved in those conversations as well. Anyone can provide information if someone asks for it, but only the medical officer and nurse practitioner can raise it. Now, you don't necessarily have to be an authorised VAD practitioner to potentially be involved in someone's care. That could be you assisting a patient of yours through VAD whilst they access VAD through another practitioner. But it could also be where another practitioner refers a patient to you for advice, what we call a referral for determination, but really for advice around their diagnosis, their prognosis, or some of the other elements about their suffering and potentially their capacity if you have a sub-interest in that. So you don't have to be an authorised VAD practitioner, but you do have the ability to say, sorry, I can't assist, workload, I'm a conscientious objector, for example, and then let the practitioner know that you can't assist, and they can go off and try and find someone else. But if you can assist, then obviously that will help the patient out, and your opinion would be greatly appreciated by the VAD practitioner. You do have the right to conscientiously object to any of those elements. Your rights, however, come with an obligation to refer the patient to a service or to another practitioner. So if you do conscientiously object, you don't have to tell the patient you're a conscientious objector, just let them know that you can't help them, and either refer them to Dr. X down the road who can help them. And if you don't know who that is, direct them to contact the statewide service who will then help them navigate. Make sure you do document that, because there are risks, I guess, if you don't document that that interaction in the medical record, and it's required under legislation. Very, very quickly, how do you become an authorised VAD practitioner? Go to the next slide. It's a fairly straightforward process. This is not a job application. We're not employing you, but it's similar to a credentialing process if you've had to go through one, not as onerous as the usual credentialing process. But you put in an application on our website, includes a CV, 2 referees, and you have to do an ID check. An ID check is actually using MyGov ID rather than you getting copies of JP certified licenses and all of that sort of thing. You do that through the government website. You upload your documents. We have a background process that undertakes verification. There's a panel that looks at all of that. There's GPs on our panel. And then it goes to the Chief Medical Officer. Once you've been endorsed, you get access to the training module. That's an online training module. It'll take a few hours to do, but you can do it at your own pace. And it has an assessment, an open book assessment at the end of it. Once you've done that, you become approved and authorized to be a VAD practitioner for 3 years. You'll then get sent a whole bunch of information around forms and access and training to various other bits of the program, including the drug protocol, the medication protocol for the VAD substances. So if we skip to the next slide, so if you get asked questions after the 1st of January about a couple of things. So first is initiating a discussion about VAD. Like I said, only a doctor or a nurse practitioner can initiate discussion. And that's really at the same time, they have to be talking about other treatment options like palliative care and also the likely outcomes of such. And if they raise VAD, then anyone can provide information. So your practice nurse, if they're not a nurse practitioner, could assist in that regard, or a junior doctor or registrar, as long as they're happy to do so and they're comfortable. But if they can't assist, they just direct them towards the statewide service. And the first request. So I know we talked about this briefly earlier, but it has to be clear and unambiguous. It has to be made by the person or with help from an interpreter or a speech pathologist. It has to be made to a doctor. What it doesn't include is if someone's just seeking more information. If someone's just making a request to a non-doctor, to a nurse, to a pharmacist, if you're raising this as an option with them, or if it's being raised as an option by someone else, not the person themselves, a carer or a well-meaning family member. So how do you respond to a first request? You can either, if we go to the next slide, accept it. Now, you don't have to be an authorized VAD practitioner to accept the first request, but you have to intend to go off and then do the training to become one. You accept it, you've got a couple of business days to let them know that you can accept it. You document that, and then you you start off the process of first assessment. But you can refuse it for potentially a number of reasons. One could be you're a conscientious objector. In that instance, let them know immediately that you can't assist them. You don't have to say you're a conscientious objector, just say you can't help them and direct them to the statewide service or someone else who can do that, and document it in their record. You might potentially be an authorized VAD practitioner or intend to become one. And so it's not a conscious objection. And in that instance, if you need some time to sort out the logistics, are you going to be on leave? Are you available? Can you see this person in a timely manner? You have up to 2 days before you let them know that you can't assist them. Again, follow the same process. Direct them to someone who can, and then document that in the record. And documentation is important here because the time between a first request being made and the final request has to be 9 days. And also this is to protect you, to make sure that you have undertaken your requirements under the legislation to on-refer. And it's not necessarily a formal referral. You can just direct them to the statewide service by giving them the contact details of such. So you just have to make sure that's documented. And then the last thing I want to cover off is around advanced care planning documents. Because the person needs to have decision-making capacity throughout that entire process, they can't request VAD in an advanced care planning document, advanced health directive, or a statement of choices. That being said, if they do want to raise that in that context, or if you're having discussion around statement of choices with you, it's very important to sort of have that discussion and use it to discuss the end of life, as I'm sure you all do. And it is important to make sure that they're aware, though, that there's no legal standing that that document or that wish will have in the context of VAD. And because it needs to be made by the person, if it can't be made by a substitute decision maker, it really then prevents any other document from being used in that context. So it's just important to know that. We are really encouraging everyone who accesses VAD or wants to access VAD to think about an ARP in case they are admitted to hospital at any point in their stay, and having those discussions around what their wishes are, I think will be useful. And if they're documented in the ARP setting and uploaded to the state system, they'll be excellent from a primary care point of view, but also would assist when they come into hospital for their hospital care. So I'm going to end there and hand back to Inga.
Thanks, Bav. That was a really informative overview. There's obviously a lot to unpack with this, with VAD. We will now hand over to Dr. Fabian Jaramillo. I'm sure that everybody is familiar with Fabian, but for those who don't know Fabian, he is the lead clinical editor for HealthPathways and has been collaborating with the VAD unit in the development of the statewide health pathway for voluntary assisted dying. Over to you, Fabian.
Thanks, Inga. Good evening, everyone. So I'll just give you a quick overview on the voluntary assisted dying pathway for the state. So next slide, please. So just some general aspects of health pathways, and hopefully you'll already be familiar with the HealthPathways platform. And in case you're not, you may request a login by contacting your local PHN or your GP liaison officer program. Next one, please. I'm using the Brisbane North HealthPathways platform as a sample here, but this is very similar to what you have in Gold Coast. On the homepage, you will find the Voluntary Assisted Dying pathway on the left-hand side menu under end of life and also under the palliative care section. Now, just to note that the pathway is currently on our draft site, and it will be made available to all regions around the state within the next couple of weeks. So you may not be able to access it just yet in your live pathways platform. Next one, please. Another way of finding the pathway is just by typing on the search bar at the top of the page, as you will do with any other pathway, or just by typing keywords or the title of the page. Next one, please. The Voluntary Assisted Dying pathway follows a similar format to other pathways on the site, with a scope statement at the top, clinical editor's note, in this case, noting that voluntary assisted dying comes into effect on the 1st of January, 2023, and that no part of the process may be initiated before this date. So you may have discussions about voluntary assisted dying, but no part of the formal request or assessment process may take place before 1st January. Of note, the pathway is general in nature. It is based on the Queensland Voluntary Assisted Dying Handbook, and it is not intended to replace clinical judgment, act as legal advice, or replace mandatory training requirements for authorized practitioners. Next one, please. The background section is followed by a section on key considerations where we discuss legal obligations, some considerations when caring for Aboriginal and Torres Strait Islander peoples and for people from culturally and linguistically diverse backgrounds. And there is also information on the QVAD support and pharmacy service. Next one, please. We then divide the voluntary assisted dying process in 2 stages. The first one being end-of-life discussions, including how to respond to a first request for VAD, information on palliative care and end-of-life care. And as with all other pathways, we provide links to existing resources throughout the drop boxes in the pathway. Next one, please. This is then followed by a section on the request and assessment process, which is undertaken only by authorized practitioners, all the way through to the administration of the substance. Next one, please. And at the end of the pathway, you will find key information on aspects after the patient's death, which includes notification and certification of the death, which is relevant to both authorized and non-authorized practitioners. As with other pathways, we also have a section on key resources for health professionals and for patients. Next one, please. So as always, once you're able to access the pathway, we appreciate your feedback. So if there are sections in the pathway that are not clear or that have conflicting information, we need to know, and we will appreciate you getting in touch with us by using the feedback button at the bottom of the page. Next one. That's the end of my presentation. Thank you.
Thanks, Fabian. It's always great to have a walkthrough of health pathways. So I'm very appreciative of your presentation. Just before we go into our next presentation, led by Leslie McLeod, I will just let our audience know that Leslie is going to jump off presentation or jump off after she's finished her presentation, but there will be an opportunity to ask Leslie questions once she's finished her presentation. And then we will pause and have a 5-minute break so that everyone can grab a cup of tea or a glass of wine and join us when we recommence. So I'll hand over now to Leslie, who's going to give us an overview of what the statewide support services and pharmacy services are. We're very lucky to have Leslie with us. Leslie is a palliative care nurse who has over 20 years experience in community services. And she is currently the Assistant Director of Nursing with the VAD unit in the role of dying support and pharmacy services. So Leslie, I'll hand over to you, and thanks very much for joining us this evening.
Thanks very much. Can you hear me? Yep. So hi, I'm Leslie from the QVAD service. So can we go to the next slide? Just before I talk about the QVAD service, I did want to just mention, this is a slide we use particularly when we've had all this information all at once, that it's just worth remembering that VAD is, we know, Bav said, it's polarizing. Some people are conscientious objectors. There are some people who are very conscientious participants, clinicians. But really, for most of us, we're probably somewhere in the middle. And so I find VAD quite intimidating as a palliative care nurse. I've watched hundreds and hundreds of people die, and I still feel uncomfortable with a death from VAD, maybe because of that, I don't know. But I guess what we wanted to say in this slide is that for many of us, we might move up and down this continuum about our willingness to participate in VAD, depending on many things. So depending on our own experience, depending on the patient. There might be some patients you want to help more than others and feel that you could do more in the VAD process for them than you could for some others. And it's just that you don't have to object or be an authorized practitioner. For the rest of us, we can support our patients and help through the VAD process in many ways, not just with those two extremes. So I guess that's all I wanted to say with that slide. That, for example, you know, for palliative care nurses that I talk to that feel uncomfortable about this, I say, well, could you provide, you know, could you help them fill up the syringe drive of the day that they propose to do VAD and make sure their pain relief's okay? And well, for most of them, they say, of course I could, it would be no different. Could you provide support and encouragement to their family? Yeah, I probably could do that. Now, being in the room while they took a substance might be a step too far for some people. And for others, they say, oh, well, if I could be there and be of help to the family, I probably could do that. If I asked nurses, could you come with me? If I had to administer the drug to somebody as a nurse, could you come and make sure I'm okay? And for many people, yeah, you don't have to be involved in VAD to help people with the process and help our fellow clinicians with the process. So that's all I wanted to say with that slide. Can we go to the next slide? So QVAD is a statewide service that's going to help clinicians, individuals, private entities, hospitals, facilities navigate this complex system of VAD, because it takes many readings of the handbook. It will take most of us experience of a couple of patients to really truly understand how this is going to work and the impacts it has. Next slide. So the QVAD support service is set up. We're based in Brisbane, a mixture of nurses. We have doctors. Liz Raymond is our lead, and she's a palliative care physician and also director of the Office of Advanced Care Planning. And she's our lead, and then it's nurses, social work, allied health, and of course our admin support. And our plan is to take calls directly from people who are considering VAD and connect them with their VAD practitioners and help sort of smooth the process so that it goes easy, because, you know, different patients are going to require different levels of support. Some people are going to need interpreters. Some people might need to travel to see a practitioner. So we also have a scheme embedded in that so that there are funds available for patients to travel to see practitioners, or for practitioners to travel and see patients. So that's part of the VAD scheme. We also plan, you know, that to support, for this to be sustainable, we have to look after that workforce of authorised practitioners. So if we go to the next slide, sorry, I might come back to that. So yeah, we need to support the authorised practitioners. This slide has just got all the different elements of things that we do, but I should also make clear that the pharmacy, so this substance that people take, these substances that people take, they all come from the QVAD support and pharmacy service. So prescriptions that are written come to the QVAD pharmacy service, and they are dispensed from only one site, and they will take the substance either directly to the patient or directly to the administrating practitioner. So it just makes it, there's no negotiating, there's no negotiating on, you know, how, about who and have they got the stuff. It's one pharmacy, one set of prescriptions, and they will deliver the substance directly to the patient and their family and explain what's required to be done in the way of storage and care of that substance, and how you mix it up and how you take it. And they'll do the same with the practitioners who are going to give the practitioner administered drugs. What else are we going to do? Manage the VAD Access program and the community of practice. So the community of practice is what I was talking about before. It's where a specific sort of education and support service to support these authorised practitioners. And certainly initially, the thought, I'd hate the thought of an administrating practitioner going to a patient's home to give them a bad substance without someone going with them. And if they don't have someone in their practice or a colleague that can go with them, one of us would go with them. So it's the idea is that you're not kind of alone in this. There are some experienced medical practitioners who've offered to allow shadowing for this to happen. So they're going to, you know, there's some coaching availability. And also it's set time aside for just those authorised practitioners to get together and be able to provide some, learn from each other's experiences and a general supportive and safe environment. But VAD also is going to touch a lot of other professionals. So people on that continuum I was talking about, that they don't not want to hear anything about it and they're never going to be an authorised practitioner, but they do want to be able to support their patients and they want information and continued learning. And we'll run a similar program for them separate to the authorised practitioner. Next slide. Yeah, it's the linkages that are a bit tricky and complex because authorised practitioners are obviously not going to necessarily want that advertised, that they're VAD practitioners, particularly in smaller communities. So we will manage that list of practitioners, which we'll keep private. We'll generate some IDs for them so that when they go somewhere, people know who they are and, you know, they've got a right to be there. If they're going to go to a hospital facility, I'll be able to tell them who they have to contact and who'll be there at the time that they attend. even down to where they're going to park their car. So we just want to make it as easy for practitioners and for patients to link together. We do get lots of questions about bereavement support, and of course, you know, we're not, bereavement support is a big empty space, and we're not going to fix that, I'm afraid, either. People going through VAD will get a lot of just general support from their practitioners and from us, and you know, we do have some inbuilt psychology support that we will make available to both patients and practitioners if required. So we are aware of it, and you know, we'll obviously do what we can within the resources that we've got. And we'll also continue to do what the VAD unit does, is that going around providing education and support for facilities who might do this, who might be open to having VAD in their facilities, and how they can do that in a compassionate and sort of human way. Next slide. The pharmacy is a bit tricky. I don't think I have a picture on this slide, but pharmacies, there's a lot more to having these drugs. We're not allowed to talk about the drugs because of, or the substances, because of the Commonwealth Criminal Code. And that's why you can't do some parts of VAD on telehealth. And but the substances we're using in Queensland are similar to substances that they might use in Canada for the MAID program. And so if people are really keen to know, they can Google it. And all the pharmacy guidelines are very prescribed and rigorous, as they should be, and we'll continue, you know, to monitor that and make sure that practitioners are happy with how they're going to be supplied with drugs and the information given to their patients. I think that's fine. And again, the final slide is about our well-being model. So not only do we have to look after our patients and our authorised practitioners, but we have to look after our staff. And because this is very new and none of us have done it before, and you know, we've got a complex structure around that to make sure that nobody's traumatized from this and everybody's supported. I think that's the last slide from me. Yeah, thank you.
Thanks very much, Leslie. I think there's some really important messages in that presentation, and also it was a very sensitive presentation, so thank you very much. If anyone has any questions for Leslie, pop them in the chat now, and we can get Leslie to answer those before she heads off. Otherwise, if anyone has questions for Leslie that occur later on and you pop them in the chat, we'll take them on notice and circulate the answers with the resources and the recording in a few days' time. So if anybody does have any questions for Leslie, pop them in the chat. All right, well, it doesn't look like we do, but again, happy to take them on notice if anyone has a question later on. Now, we are going to have a 5-minute break, so we will recommence at 7:27, and we'll kick off with Tricia Mathias, who's going to talk about some of the border considerations for Northern New South Wales residents. So we'll be back 7:27 with Tricia. Okay, welcome back everybody to the webinar this evening on voluntary assisted dying. We'll now hear from Tricia Mathias, who's the Project Executive Director of the VAD unit. Tricia is responsible for leading the implementation of VAD in Queensland. She's a highly respected policy and legislation expert, and most recently, she has led the VAD Bill 2021 debate process and successfully managed the fast-moving development of the Chief Health Officer's public health directions to assist in containing and responding to the spread of COVID. So I'll hand over to Tricia, and again, very similar to Leslie, we'll open to questions from the audience for Tricia after she's finished speaking. So there will be an opportunity to ask her questions directly after her presentation. Otherwise, we'll take them on notice. Over to you, Tricia.
Thank you. So I just want to take you through the specific requirements in the Voluntary Assisted Dying Act around residency. So if we just move to the next slide, this isn't in the Act, but this is part of some advice we've received around and questions we get around where can voluntary assisted dying occur if someone accesses in Queensland, and this is particularly relevant to border communities. So for a person to access voluntary assisted dying, they need to be in Queensland, and their doctor needs to be in Queensland for the process when they're doing assessments and all those steps that Bav took you through earlier to get the protections of the Queensland law. So if it's done outside of Queensland, even though other states might have their own laws, those laws don't apply to a process that's happened under the Queensland laws. So it's just important to note that, if you don't have to reside in Queensland as a doctor, but if you're actually undertaking any of the assessments, they would need to happen in Queensland. I've just moved to the next slide. So what are the residency requirements? So under the Act, a person, they have to have sort of Australian residency and then Queensland residency requirements. So the Australian residency requirements are that they're either an Australian citizen, they're a permanent resident of Australia, and that includes New Zealand citizens who hold a special category visa under the Migration Act, or they've been ordinarily resident in Australia for at least 3 years prior to making their first request. Or if they don't meet any of those criteria, they can apply to Queensland Health for a residency exemption. So I'll talk about that a bit more in a minute. And then the Queensland residency requirements are that they have to have been ordinarily resident in Queensland for at least 12 months before making a first request. Or similarly, they can be granted a residency exemption from that requirement by Queensland Health. So someone might be a permanent resident of Australia, but not have resided in Queensland for 12 months. So they would seek an exemption from that Queensland residency, or alternatively, they might have been for some reason in Queensland for quite some time, but don't meet the other Australian residency requirements, and they can seek an exemption from that. And what does ordinarily resident mean? So that's someone who regularly or normally lives in Australia or Queensland, and it doesn't include people who live temporarily in a place, for example, just on a holiday or business or education, but it's just where your ordinary residence is. Sorry, I know you want to go, keen to go to the next slide, Inga, so that's fine. Thank you. So to get an exemption under the Act, a person needs to have a substantial connection to Queensland and compassionate grounds. So a substantial connection to Queensland, some examples are a person who's not a citizen or permanent resident of Australia, but have been living in Queensland for several years, or are long-term residents of a place close to Queensland border, and they work in Queensland and receive medical treatment in Queensland. So that could be someone on the New South Wales border. Or they live outside the state but are a former Queensland resident and have family who live in Queensland. And compassionate grounds will be considered on a case-by-case basis, but given the situation people will be in, that's probably not as significant as having to create that or prove that substantial connection to Queensland. Next slide. So in terms of the application process, so if a person makes a first request for voluntary assisted dying and a doctor accepts that, and then as they're going through the process and they have confirmation that the person meets the other 4 eligibility criteria, but they get to the point where they're unsure about the residency, or it's quite clear that the person's not a resident, they can then apply to the Voluntary Assisted Dying unit within Queensland Health for a residency exemption to be considered. That will be assessed quickly, and if more information needs to be sought, that will be asked for. But part of that application, we do have a form that we'll put up on the website to assist people with the type of information that's needed. So it will have, ticking the reasons why they're seeking voluntary assisted dying in Queensland, including that criteria around their substantial connection to Queensland. And they'd have a letter of support from their coordinating doctor that the person meets the eligibility criteria, but they just don't meet this eligibility criteria. And a substantial connection to Queensland could be a letter from a family member, evidence of former residency in the state, medical records showing that they have treatment in the state, or employment records that a person's worked in the state. And so if they're granted a residency exemption, they just continue on, and the coordinating practitioner then uploads that as part of the form that's done for the first assessment. And if they're not granted a residency exemption, the process stops. But they can also seek, there is a right of to go to QCAT, so the Queensland Civil and Administrative Tribunal, to seek their review, not of the Queensland Health decision, but if a practitioner says a person isn't a resident of Queensland, they can seek a review through that process. And then that's it for me. So I just wanted to really touch on that, given that the proximity of the Gold Coast to Northern New South Wales and the experience everyone's been through with borders over the last few years, and the number of people in Northern New South Wales that potentially access services in Queensland. So this question may come up. We will send, once that form is live on our website, we can send that link through to the PHN so that you've got that, and there'll be some information around the process up on the website as well. So I'll just pause there and see if anyone had any questions around that.
Thanks, Tricia.
No worries.
I don't see any questions in the chat, but if anybody does have questions, pop them in the chat now for Tricia to answer. Otherwise, we'll take them on notice. I think it's an incredibly important point to highlight, especially, as you said, with all the border closures that we've all experienced over the last 2.5 to 3 years with COVID. We are aware of how interconnected some of those New South Wales residents are to Queensland Health Services. So I think that's a really helpful and good thing to know, that there is a process to follow should anybody be wanting to choose VAD. I don't see any questions, Tricia, so if I can just extend a thanks to you for presenting tonight and for all the work that you're doing with the VAD unit. I know that you've all been doing a lot of work, so we appreciate that you've spent some time with us this evening. Okay, we'll keep moving on and go to Gold Coast Health now, to Tamron Dart, who's the project officer for VAD through Gold Coast Health. Tamron is responsible for developing a local model of care, providing information to staff, recruiting to the Gold Coast VAD service, and engaging with stakeholders. Prior to undertaking this role, Tamron has worked in the Gold Coast Health Clinical Governance Service as a safety and quality coordinator. Tamron has been a registered nurse for over 20 years in Southeast Queensland. So I'll hand over to you, Tamron.
Thank you, Inga. So if we just go to the first slide, please. Thank you. So as most of you are aware, Gold Coast Health is obviously a public non-metropolitan tertiary hospital and health service, and we provide care to, as we've mentioned already, a rapidly growing and diverse population of more than 690,000 persons across our Gold Coast region and into northern New South Wales. We're delivering care at the moment from 20 facilities, including 3 hospitals, that being Gold Coast Uni Hospital, where I am at the moment, Robina Hospital and Varsity Lakes Day Hospital. We have 2 allied health precincts currently, one at Southport and one at Robina. And we have some other facilities that are being built at the moment. So that'll be Coomera in the coming years. And we're also one of the largest employers in the area, with nearly 9,000 highly talented and committed full-time equivalent workers. So a very big organisation. And our Always Care philosophy is essentially what underpins our vision and our purpose and our core values, which I've outlined there. This philosophy, Always Care, is something that is echoed in our commitment by all staff to deliver person-centred care to our consumers in the community. Next slide, please. So this is a little bit of a roadmap, I suppose, of our journey so far in implementing the legislation across Queensland. So the Act was passed in Parliament back in September of 2021. So we've had just shy of 15 months to implement this legislation, have it ready for implementation on the 1st of January. We've been quite busy in establishing a lot of our systems and processes. And Gold Coast Health has probably really hit the ground running once Bav joined the service in July and became our local clinical lead, in addition to his statewide role. From October, which is when I joined the team, that's when we started to receive a lot more of our statewide resources, and my role then became more about adapting those resources and making them suitable for Gold Coast Health. We have a lot of work that's underway at the moment in terms of building our referral processes and working with coding teams and establishing billing. We're in the midst of our recruitment to our model of care that's also in development, and we have a number of engagement activities that are coming up in the coming months, and making sure that all of our staff feel very confident once the legislation goes live. I think Leslie mentioned earlier, this being something that's so new to healthcare workers, and something that in a way goes a little bit against our training, where we've always been trained as healthcare workers to preserve life. This, of course, will be challenging to some of our peers, some of our clinicians. So it's important that they're informed and that they feel confident as we embark on this next journey in healthcare. Next slide, please. So this is the model of care that we're working towards. And I think part of my role is, yes, developing that model of care, but it's doing that in partnership with our local project team and our steering committee, which consists of a range of representatives from across the health service, including legal, from risk. We've got psychology persons involved, our nursing executive. We have members of our consumer advisory group as well. So they will be consulted throughout this process as we go on and develop our model of care. And whilst we've talked a lot this evening about all of the theory, I think it's important that we remain quite fluid, because once we start to operationalise this and we start meeting our patients and working with them on this journey, things might need to tweak or change a little bit. But Gold Coast Health essentially will be providing a supportive service that will be continuing to collaborate and support and be compassionate when delivering care, and of course respecting the person's experience and their end of life request. The model of care we're thinking is going to be predominantly community based, So we'll be seeing patients out in the community in their homes, in our outpatient appointments, but we also recognise that some of these patients will need to enter some of our tertiary facilities for inpatient care. So it needs to incorporate aspects there as well, and it will be a multidisciplinary approach. Next slide, please. So operationally, I guess this is what our model of care is looking like at the moment. So we'll be based under an organisational clinical stream. As I mentioned earlier, we're in the middle of recruiting to our Gold Coast VAD nurse coordinator role. When we've been networking with a lot of the other project officers throughout Queensland and the other HHSs that are doing this body of work at the moment, we've found that that role is something that would be essential in, I guess, navigating patients through a very complex healthcare setting and a very complex pathway of care. So at the moment, we've done some interviews and we've got some nurse practitioners that will be stepping into that role. We thought nurse practitioners would be more of an asset to our service because they do have some extended scope under the legislation. We've been fortunate enough to recruit those internally, and we have 2 people commencing in the role in early December, and they'll be in a job share arrangement initially, looking at 0.6 each, so we'll have 1.2 kind of covering the role. And there's some added benefits with that because it'll allow them to have some peer support and to be there, I guess, to hold one another's hands as they embark on this journey. It'll allow for a little bit of backfill and leave and to expand the service if we feel that we need to do that, even though, you know, we have some predictions in terms of what demand will look like. That may change after the 1st of January. In addition to that, we'll recruit to an administration officer to support these processes and set up appointments and things as we need to help manage with referrals and to make sure that all of our administrative tasks are undertaken. In terms of clinical lead, that role is still evolving. And it may end up being that we have a bit of a job share arrangement there as well with people that either have an interest in voluntary assisted dying or whether or not they're a GP with a special interest that want to participate in this program. But some of that will come out of our existing medical officers who have gone off and completed the training to become VAD practitioners. In saying that as well, I think Leslie mentioned about the staff wellness, we'll also be making sure that we're making use of our Always There peer support program, which is our local support program, to ensure that all of the staff that are involved in this program of work and in providing this care are supported. Next slide, thanks. So earlier we mentioned referral pathways, and in addition to that, we'll have the option at Gold Coast Health to refer your patient. And for any sort of concerns that you have, you'll be able to contact that Gold Coast Health VAD nurse coordinator positioned for assistance in terms of how you will be able to refer, but more or less it'll be similar to how you refer into our service at the moment. So we've been working with Nalani Cox, who some of you may be familiar with. She was responsible for launching smart referrals here at Gold Coast and did a lot of work with the PHN to establish that. But our referrals will generally be received from our GCH clinicians or other HHSs, GPs, private specialists, or they may come down from QVAD support. We'll be receiving referrals through fax or secure web transfer or our GP smart referrals process. VAD referrals to Gold Coast Health are able to be managed within the 5-day KPI as per best practice. And given that this is an emergent care, that should really be appropriate. The model should be operating from a Monday to Friday, so that 5 days should be covered. We don't have any specified referral guidelines at present. There are some essential referral criteria that will assist in ascertaining eligibility, and we talked about the eligibility criteria earlier. Just the next slide, thanks. Just a bit more of a diagram, I suppose, of what the referral pathway will look like. We'll have our internal and external coming through. They'll go through that initial intake hub. where we have a 4-hour KPI on the turnaround there, and then these will be forwarded on to that administration role that we talked about earlier before being sent through to the VAD nurse coordinator to kind of do those initial clinical content reviews, determine if it meets the criteria, and make notes of booking instructions before returning that information back to our VAD admin officer so that they can contact the patient and book them in to be seen as they need to be. I think that's probably all for that slide. Next slide. A referral may not be accepted if the patient lives in a surrounding HHS catchment, and these will be redirected as appropriate to the suitable health service, or as we talked about earlier with the eligibility criteria, if they're under 18 years of age, we wouldn't be able to accept those referrals. And then next, I think, is just the contact information for our nurse coordinator once they commence. The phone has arrived and the email is open and it is being monitored at the moment. So if you have any questions for our local team, you can certainly get in touch with us. Thank you.
Thanks, Tamarin. And I'm sure all of the contact details will also be distributed by the PHN and of course by Gold Coast Health as well. So we look forward to liaising with them. Thank you very much for your presentation. It's really helpful to have insight into the local process. Now I'm going to throw open to questions from the floor. So if anybody does have any questions for our speakers that are with us at the moment, including Bav, Fabian, Tamarin, please put them in the chat now. We'll hang around to answer any of those questions that you might have. Alternatively, we can also take questions on notice should there be any questions for Leslie or for Tricia.
Inga, whilst we're waiting for those, just to follow up on something that Tamarin said about our model of care at the Gold Coast HHS. So what we're providing there is a support structure for the doctors who do participate. We obviously can't force anyone to do the training. We strongly encourage people to do the training, including our own employees. But if you do have an interest as a GP in doing the training, becoming an authorised VAD practitioner, we do encourage you to let us know. And so if there is support that we can provide to you, we can do that, because this is something that can occur in primary care just as much as it could occur in the hospital setting. And if there's any way we can support you in providing services to your patients in primary care, so you don't have to hand them over as such to us or have fragmented care, we'll be very keen to support. We're very keen to make sure that patients in the Gold Coast are getting the best care around this. So please get in touch if we can assist. And just also that the legislation does allow GPs to enter into facilities to provide care for their patients for VAD. So if you do have a patient that's under our care and you need to, for other reasons, and you need to enter to provide VAD services, we'll have some local rules and legal requirements around things like vaccine preventable disease and the usual things that we need from our doctors when they provide care. It's not going to be onerous. It's not going to be a full credentialing process or anything like that. But just get in touch with us and we'll let you know what that process will be. And Tamarin mentioned GPs with special interests. It is something that we're exploring at the moment, whether we have some casual positions available for GPs who've done the training, who might be available as required or when they're able to assist with some of our patients requiring VAD assessments. And that way there's a remuneration model where you'll be an employee of the HHS for that period of time for payment. So we're just exploring different options. If there's anyone out there with an interest, wants to have a chat, please get in touch with us and we'll help.
Great, thanks, Bav. Well, we still don't have any questions in the chat. So obviously your presentations were very comprehensive, which was great, but I'm sure that we will have follow-up questions further down the line. So a reminder that the recording of the webinar will be circulated by the PHN over the next few days and be available on the PHN website. And that recording will also go out with the resources that were discussed this evening. I would like to thank all of our presenters that were with us tonight. As I mentioned earlier, I know that they have been working tirelessly across the state. Somebody did mention that they've done over 200 presentations this year alone. So we are really appreciative to have them with us this evening. I think it was a very informative and insightful webinar for all of us. So thank you, everybody. Like I said, if anybody does have any questions that they would like answered by the panel, please get in touch through the PHN if you're unable to get in touch with the VAD unit. All right, well, good night to everybody, and thanks for your participation.
Thanks, Inga.
Thank you. Thank you so much.